Well, good morning, everyone. I'm John Miners. I lead the mission aligned business and healthcare solutions for the American Heart Association. And I want to thank you for joining us for this topic this morning in our webinar on AI access across healthcare systems. We have planned a brief agenda for you. I want to share a little bit about what the organization has been doing in recent years around AI. And then we'll kick off a roundtable with some of our thought leaders that have volunteered their time to help us and create the solutions that we're going to be discussing today. I think this work, it's obvious that AI is going to have transformational impacts on healthcare. And a year ago, our board commissioned a task force on AI to look at the ways that American Heart Association can leverage its unique competencies as a science organization, one that invests in research and writes clinical guidelines for patient treatment, advocacy, and the like. So some of the comments that I'll make are about that work over the last year and how that's led us to some areas of opportunity where we think AHA's unique competencies can be valuable in bringing forward some of the promise that we have in this new area of technological health. The main process over the last year has been what I'll call a listening tour and spending time with hundreds of stakeholders from developers, hospital systems, to policymakers, patients, et cetera, to understand what some of the unmet needs are. Some of the things we're hearing, of course, the word trust comes up a lot, but what does that mean? Well, essentially, what is the efficacy? What is what's the accuracy of some of these algorithms, if you will, and what are some of the variables and things that could occur in unattended ways? So one of the clear first things that we heard was, where's the practicality of testing these solutions to understand and to be able to communicate to providers and potentially to patients what the actual algorithm is determining in its accuracy, if you will. We also wanted to understand if there was unintended bias based on the data sets that it was trained on. And ultimately, we feel like those, if they're communicated correctly and in a objective way, that we can build trust and streamline adoption with more transparency. So the first piece of unmet need was clearly around this area of assessment. And then we also understood that, there's a question of, resources and the unmet needs and uncertainty about what's the total cost of ownership of onboarding these AI solutions. What is the potential improvement in efficiency, and what is maybe the potential opportunities for reimbursement and reimbursement of care. So in essence, the total impact, not just on the fiscal pieces, but also maybe on workflow. If the AI algorithm is implemented and overloads the clinical workforce or the cath lab, then that's an unintended consequence. And data related to that before implementation would be extraordinarily valuable. And the other thing we heard was that there are large academic medical centers that are doing a really good job of implementing this. They have teams, literally dozens of data scientists, analyzing data, developing algorithms, validating them in their healthcare systems environment. And so there's, at least a handful of these large academic medical centers that I think have very good systems that we're learning from. The challenge is like any new intervention, whether it's a new drug or therapy or device, it's not available to all immediately. And in some cases, those barriers to entry are quite formidable. And that is the case with AI. So we're seeing a growing disparity, and alarmingly so, between the larger healthcare systems with these, deep capabilities around data science and those that don't. That will create increasingly, and we see differences in ability to implement AI for the purposes of efficiency and clinical performance, and ultimately leading to disparities in resources. And alarmingly for the American Heart Association, these smaller systems or rural hospitals, critical access hospitals, are closing their doors, and that creates an enormously challenging opportunity for an organization like ours. Many of the cardiovascular and stroke conditions are time sensitive emergencies. So access to care and timely access is an extraordinary issue for us. The As we continue to sort of listen and think about what the opportunities are, we're looking for those that would be unique to AHA and what our key competencies are as an organization. We've been writing clinical guidelines for over 100 years, and weighing evidence and funding research. Are fortunate to have thought leaders from around the world that participate in those processes and volunteer their time and their talent to the greater good of collating the best possible clinical decisioning tools. And we've been involved also in collecting data. We've had the Get With the Guidelines registries now in over 3,000 hospitals in the U.S. For more than 20 years. So we have some deep understanding of clinical data and how it's can be used for clinical performance evaluation. So that's led us to now thinking about the way to help bridge the gap. We realize that these large academic medical centers have things well in hand, but we're looking for a way to take that knowledge and scale it to a service for those that don't. And speaking to those three areas of opportunity that I just mentioned of unmet need, we think that there's an opportunity to provide a transparent system for evaluating algorithms, and working with a company that we've been working with for quite some time, over a year, with Dandelion Health. Dandelion's network of hospitals is more than 60, and geographically dispersed throughout the country. They are also unique in the sense of how multimodal their data is. And we're going to talk a little bit more about that because we see many of the most promising algorithms currently in things like imaging and radiology, not just things that would be derived out of a electronic medical record. So there's clearly opportunities here in the unmet needs we heard from AI developers, also healthcare systems as they're implementing these to make decisions about which ones should they implement, which ones shouldn't they, what's the long-term cost, and how would they monitor it once it's been deployed in their system. So here's the three products that we're in the process of developing, and some of these already exist today. The first is a performance report. It speaks to the question of how does the algorithm work? How does it work within, toward its intended purpose? We have this performance report available now for EMRs, ECGs, echo, and in a couple of months we'll have it for CT and MRI. So any of these algorithms that that exist today could be run through this evaluation process and provided a report on their performance. The second speaks more to the fiscal impact or the workflow impact. We think, number one, understanding the costs and the potential reimbursement opportunities, the opportunity to see additional clinical unmet needs is an important part of the analysis and decision process. But secondarily, we also need to understand the workflow implications. If the algorithm is implemented and then triggers so many opportunities that the clinical teams or the radiology team or the cath lab, et cetera, aren't able to handle those, this type of report will allow you to in essence, triage or titrate the implementation so that it doesn't overwhelm the physical limitations of the particular system. And then finally, when these things are deployed, testing them on a regular basis. We've proposed quarterly that there'd be a service or opportunity should a developer or a system want to have something that automatically sort of does this and produces a report to ensure that there's no drift or unintended things going on in the underlying population base or the algorithm itself, are the three areas that we're focusing on initially. These last two pieces are still under development. We expect to release them in the fall. And wanted to share where we are in sort of this development. I think many of our thought leaders, and I would say we don't have all the answers. We're just trying to begin the process and being part of the ecosystem to find the answers and to develop these solutions. So I'll say, additionally, this is the expert panel that we've assembled that's worked with us over the last many months to develop well, first identify the unmet needs in the areas that AHA is uniquely qualified for, and then to help guide the development of these tools along with our technical partner, Dandelion Health. Many of these are well known to you, and one I'll be introducing to you in a minute is Lee Schwam, who's co-leads our AI task force and has been quite involved in our efforts at the American Heart Association in quality of care. A little bit more about Dandelion. We started working with Dandelion in sort of federated learning efforts that continue to this day. But one of the reasons we've chosen them for this project is their deep abstraction and analytic capabilities in 4 healthcare systems, which are their primary clients here in the US. But one of the most defining factors is the multimodal data that they're able to ingest and to analyze. As I mentioned, they are exceptional at not just EHR, but the imaging data, the waveform, and other areas where these algorithms are showing great promise. So I think it's a natural synergistic partnership between what the AHA brings and Dandelion brings to this equation. So this is kind of their footprint and the healthcare systems involved with the data set that we'll be measuring against. This, initially will look like us configuring a data set or digital twin, if you will, within the Dandelion environment. And that data set of 73 hospitals and 13 million patients that mirrors the environment of the target hospital or the target implementation that we want to evaluate. Now, admittedly, that's not local validation. We're not saying that local validation shouldn't happen in hospitals where they have the capacity to do that. But we're trying to find a solution that meets us where we are at this date. Long term, I mentioned the federated learning model. We'd like to move past this digital twin model where we're mirroring and simulating the actual and validating against a simulated model of data to actual local validation. But the technologies aren't quite there yet. One day we would like to be able to do local validation in every hospital. And as we get the federated learning models to be more efficient and well-tuned, I think that's ultimately where this will go in the long-term future. The last thing I would want to say is that we're looking forward to developing these solutions in partnership with others. It's one of the main core fundamental principles behind AHA is finding partners that bring complementary skill sets and organizations to the table. This call is really about just sharing where we are in that evolution and inviting those of you that are interested in maybe being early adopters to take advantage of the solutions that we have today, or helping shape the future for some of these other capabilities that we'll have in the next few months. It's a time to raise your hand, and we'll share a contact with you at the end of this call to follow up with more information, as well as we plan to have a second call that'll be much more interactive and the opportunity to ask live questions in about 2 weeks. So with that, I wanted to turn it over to our moderator today, and somebody that's well known to many of you, Lee Schwam. Lee's been a volunteer for as many years as I've been staff. I've been with the American Heart Association 35 years, and I think he's probably been with us longer than that. He's currently the Senior Vice President and Chief Digital Health Officer at Yale School of Medicine. As I mentioned, he serves many roles with the American Heart Association, including involvement in helping lead our AI task force over the last year, leading our health tech advisory committee. And I think most remarkably, he was one of the innovators that created our quality registries 20 some years ago, the Get with the Guidelines program, which many people are well aware of, and has been the benchmark in driving increased compliance with clinical guidelines. So with that, Lee, take it away.
Great. Thank you so much, John. And I just thanks to you and Jen Hall and the amazing team of AHA staffers who've been working on this new space. Before I introduce the panelists, I just want to maybe say what is maybe on everyone's mind here, which is why AHA, right? Why is AHA in this space? You alluded to it to begin with, but my spin on that is that AHA has a legacy of providing guidance to professionals like me in how to implement the safe, equitable, and responsible translation of evidence into practice, and then measuring the impact and adoption of those practices. You mentioned Get with the Guidelines. That's essentially just a description of Get with the Guidelines. I don't think AI is any different. I think AHA needs to be in this space. This is clearly an important part of the future of medicine, and you have to be inside it to understand it, to know its strengths and weaknesses, and to learn as you go. No one has the answers. The only mistake you can make is sitting on the sidelines, I think. So I'm very honored to be asked to moderate this roundtable with this amazing array of experts. So you will hear in the course of the next 45 minutes from Dave Newman, who is the Chief Medical Officer and Virtual Care Leader at Sanford Health, Sneha Jain, who is a Clinical Assistant Professor of Medicine and very involved in the AI efforts at Stanford University, Cyril Ofori, who is a cardiologist and the Chief Science Officer at Worcester Community Hospital, Elliot Green, co-founder and CEO of Dandelion Health, a partner of the AHA, and then Ross Upton, who is the founder and CEO of Ultronics, which is a company that we're going to hear about in a moment. So let's kick things off with the developer's journey. So Ross, maybe I'll start with you. You've been building clinical AI systems for a long time. I believe you have FDA approval and reimbursement for at least one of your products. Tell us a little bit about the unexpected challenges or surprises when you went from building an algorithm to actually trying to get it implemented in a clinical environment. And what do you wish had existed for you and the company when you started this journey? Give us, maybe just an example or two of what that experience has been like, what you've learned.
Absolutely. Yeah, happy to. And yeah, thank you for the invitation to speak today. Yeah, as you rightly pointed out, we've been developing AI products for echocardiography for 8 years now. So we have 6 FDA clearances, 3 reimbursement codes, and we've been deploying these products across the US for a couple of years now. So our products specifically work on echocardiography in the fields of heart failure and cardiac amyloidosis. The thesis being we're trying to find grossly undetected diseases where there is an effective therapy available for the patients. So that's the goal of what we're trying to do. I would say some of the challenges we've had, I think when you start as a company and a startup in this space, you always look to the FDA as your big milestone to achieve, as a big thing that you need to get through. And once you get FDA clearance, you can go to market and you can get your product out there for these patients. I wish that was true. I think that the reality is that there are many more steps. The FDA clearance is just the first step in the process. I think you have to have rigorous validation. The validation the FDA makes you do is they ensure it's safe and it's effective, but it's often, closed validation. It's often retrospective. It's often not the kind of data you're going to run up against in the real world. And then when you get to the real world, you get in a situation where your algorithm comes up against all of these unknown unknowns. And you're both experiencing it from a company point of view, but then the customer is also experiencing from their point of view as well. And so anything that can help reduce that friction. I think this kind of need for an AI assessment lab is a big one. And I think as a startup, if I had that available to us back when we were first deploying, it would be muchly appreciated, and it would have helped speed up that journey.
And I think I really love the way you emphasize both the necessary but not sufficient aspect of FDA approval. Although I would argue there's plenty of algorithms out there that have never been FDA tested and are being deployed, but maybe not marketed, but certainly deployed. But there is a real difference between device approval and drug approval in this country. You don't get a drug approved without showing clinical efficacy on agreed upon meaningful clinical outcomes. You get a device approval because the device does what it says it does, whether or not it impacts clinical outcomes. So I feel like there's another hurdle here, which is just starting to occur in the maturing of this space, which is clients like health systems want proof of not just effectiveness, but they want proof that there will be a meaningful impact on clinical outcomes. How will the care be different, or how will the outcomes be different based on the use of this technology, which is a much higher bar to cross? And I wonder if you've given thought, Ross, to whether or not that is actually a responsibility of the vendor or some intermediate party, or even the client who is going to consume the product. Where do you sit on that? And then I'm going to ask others kind of their opinion about that.
Well, I think the answer to the question is there's a big gap in that. There is a big gap that something like an AI assessment lab could fill here. I think the responsibility is probably shared, but certainly the onus is on the vendor to provide that. I think when the next stage after FDA clearance is often with AI tools is reimbursement, but it's very difficult to sell the AI tool without reimbursement, given hospital margins. They need some value creation, some reimbursement to pay, and you have to do many trials showing the value you create to even be able to get a reimbursement code. And as a startup, that is very capital intensive to do that, and it's very time consuming. And we went through all of those hurdles. We did retrospective, prospective, real world validation to show efficacy. And still today, with our providers, with our customers, they're still asking us to provide validate it at a site-by-site level, even though we have all of those things in place. So there is a real gap there that someone like the AHA could come along and say, this has gone through our AHA assessment lab, and we can certify that and give customers confidence that this algorithm will hold its performance in their site.
So let me turn to Cyril for a moment. Cyril, you're at a large community hospital. I'm going to guess you probably don't have an AI development shop within the health system, but you've probably either purchased or been thinking about purchasing an AI solution. Where's the bar for you? How much proof do you need from Ross to want to engage and purchase his product? And do you need more proof to buy it than you would if Ross said, hey, I want to partner with you to help prove out that my product works in a community setting? Where's the threshold for you right now as a leader in this space in the community setting?
Thanks, Lee. Yes, in a non-academic, non-tertiary care institution such as ours, it's always difficult really convincing the healthcare system how do they adopt these platforms or algorithms. What is it going to cost? We have to emphasize the importance of the accuracy of diagnosis, the appropriateness of diagnosis, and the implications for therapy. Some people have mentioned hypertrophic cardiomyopathy or amyloid or aortic stenosis. These diagnoses always lead to expensive treatments, and we have to make sure that these treatments are appropriately utilized, and bearing in mind that we got to prevent the differences between different patient populations which may arise as a result of this digital divide. The healthcare systems always want to know whether is there going to be a cost savings? Is it going to prevent readmissions? And I think one of the things that's going to help is to have an advocate in the system, such as a science officer, someone who is interested, because this is completely new territory. We've had chief medical officers as well as regulatory officers, but science officers in smaller hospitals is a new thing, especially with the advent of AI. They also mentioned whether some of these algorithms will be vendor specific, because some of the hospitals already are committed to certain vendors and they want to know, are they compatible? How much is it going to cost them? And the last point that I want to make is also with respect to recruitment. As smaller hospitals have difficulty recruiting specialists, and especially experienced specialists. And the hope is that some of these algorithms would help to blunt the differences between experienced specialists as well as newbies who probably need some mentoring. But I think one point that I want to make is these hospitals do need an advocate for this kind of platform or algorithms to be instituted, and I think it would benefit them. And to have AHA behind something like this, I think adds a lot of gravitas.
So I'm going to get to you in a minute, Sneha, because this is like your whole field. So don't worry, I'm coming to you for a more thorough conversation on this. But I want to just ask Dave for a moment. When you think about integration of these tools in your health system, two components I'm interested in. One is, how much do you think about the workflow sensitivity of these algorithms? It works in hospital one's workflow, but it doesn't work in hospital two, or how much do you have to worry about that? And how much does that then drive you toward wanting solutions, for example, that are delivered through your EHR? Like Epic has a new, all-you-can-eat buffet sort of approach to its AI suite, and it's continuing to add to that. How, as you think about system deployment now, not just at a single hospital, how do you factor that in, and what kind of proof are you looking for from the vendor that they have actually tested this, not just because they've pulled patients from across different health systems to create a representative sample of patients, but that it's actually a sample of different workflows?
Yeah, I think it's a phenomenal question, and the one that is on all of my patients' and providers' minds. So at Sanford, we're a huge rural system, multiple hospitals, but we also partner with Community Connect partners to lead their technology drives. John said when he started the conversation, institutions don't have the time, the expertise, or the budget to validate these things. At Stanford, we do. We have our in-house AI shop, which helps us ask questions. Right now, I'm at the point where we don't start AI processes like Ross do. We finish them, we operationalize them, we bring them to patients. The hardest part in my mind has been change management. A lot of these processes work. I have to convince 50,000 employees that they work. There has to be change management built in. My biggest failures have been when it's been a really great product and I couldn't convince people to use them. The way we do this typically is with transparency around evidence. Providers typically listen to evidence more than they listen to anything else. The same way, if we were convincing them to use a new medication, we have to have data. We have to have large data, and we have to have data that pertains to our patients. That's where partners with like the AHA and Dandelion can really help us with that. You also want to be problem focused. We want to start with the problem, whether it's how can AI help us decrease time to treatment for rural strokes? How can AI improve our nurse practitioners and PAs who are the only provider in rural communities? How can they use AI to help their patients with statin adherence? These are the things that we're looking for our vendors and our other partners, such as the AI, to help us with guidance on change management.
I love that. And you just sparked a new phrase in my mind. Instead of drug detailing, we need AI detailing. Like we have to bring the evidence that will be compelling to the people who need to adopt. And as I have said many times, I did not go into medicine to improve prior authorization, right? So we really want AI tools that are going to address more than operational efficiency. Margins are important, but the real power of these tools is going to be to improve patient health. So let me shift the conversation now over to you, Sneha, because you know, this is a main focus of your research, and I think a cornerstone of your career is thinking about responsible evaluation of AI in cardiology, but I think the rules will generalize broadly. So reflect on the prior conversation, if you would, and talk to us a little bit about how you think, how we practically can approach things like assessing for bias, or what should the clinical validation threshold be? Should it be uniform regardless of the algorithm? Should it be risk informed based on the nature of the algorithm? And how do we manage the total cost of ownership around these algorithms when the vendor wants X, but it's going to cost us X plus Y to actually implement and run this thing? So you know, share some of your thoughts with us now.
Absolutely. And thanks for the easy question, Lee. But I think that there's been so many great points that have been raised already today. And I think a lot of this ties back to the first comment you made, Lee, which is why AHA. And I think something that Ross mentioned, and we heard Dave talk about too, this change management aspect is so difficult. You can have a great algorithm, you can have done all this work up front, but getting it to the providers and to the patients to actually create impact and value requires so much more than the AI tool itself. And so, and I think that unlike some other technologies where you develop the technology, then you validate, then you deploy, AI is so much more iterative than that. And I think it's imperative, and so I'm so glad that the AHA and other professional societies are getting involved in this kind of work, because you can infuse the values of the profession, the physician and the patient voice into the design and assessment process from the early stages to help guide the way the technology is developed and then ultimately deployed. And I think that that piece is critical and a key role that AHA is going to play. And then in terms of what assessment is needed, Ross mentioned that each site wants local validation. And I think that this can be important because you do want to make sure that the tools are working in the way you expect in local context. And so I don't think the solution is getting rid of that burden of proof, but rather making it much easier to obtain that proof that's needed. And that's really what can be catalyzed by these assessment labs. And to answer your question about, like, you know, is it kind of the same kind of evaluation for everything or risk-based? I think it has to be risk-based. You don't need a full-blown clinical trial for an AI tool that, you know, quickly measures something on an imaging scan that can be validated just by a physician making the same measurements. You don't need a full-blown clinical trial for that. I think it would be a misuse of resources to do a full-blown clinical trial for that. But for things that are guiding therapy, guiding care with real patient risks, yes, we need a higher burden of proof. And I think what this is foretelling is really not only a revolution in AI and technology, but a revolution in how we think about evidence generation in this field. We spend so much time thinking about phase 3 trials for drugs and for devices, but I would argue that even more important than the phase 3 for AI tools is the phase 4, the monitoring of the performance of the tool and the impact it's creating, so that we know, health systems know whether to continue to use the tool or to turn them off. I think we're going to have a real conversation about when we should turn off tools, so we don't just end up with hundreds and thousands of tools that are running without us as health systems, as societies, and as providers knowing if they're actually creating value.
You know, you triggered some really interesting thoughts for me while you were talking about that. The first one is, it's still 15 to 17 years for a drug that's proven effective in a phase 3 trial to actually make it to patients. So we're probably doing better with AI than we are with drugs, but we still have that practice gap. But also, you know, we have all sorts of what I would call primitive AI running currently, which we have since I started, which were nomograms, right? Those are logistic regressions. They're predictive algorithms. I don't know the last time anyone looked at their population and validated whether the CHADS2 VASC score actually predicted stroke risk in their population, right? We do a terrible job in that post-validation monitoring component. It's where I think the biggest hidden total cost of ownership actually is. And I agree with you. It takes a mountain. You have to move a mountain to get people to look at those algorithms again. And look what all of the Black Lives Matter and all of that racial kind of consciousness and awareness that it took for us just to look at removing race from algorithms that had nothing related to race, but race had been baked into those algorithms. So I think you're right. That's the other side of the change management. It's change management around how we think about evidence generation and what what's good enough? Cyril, you know, I was reflecting on this issue around digital divide and thinking you had mentioned it in your comment. These tools are a two-way street. Some of them are, you know, the doctor's the only one who sees the tool, right? You have an image done the usual way, the doctor looks at the image, the AI looks at the image, the doctor picks the best of both. But a lot of these tools are going to increasingly involve patient engagement. And how do you think about the fact that we sometimes worry AI is going to be inferior to routine in-person care, but quite frankly, it's in some cases might be superior. How do we make sure that our patients with lower digital literacy, lower health literacy, lower socioeconomic means can still be part of this revolution in healthcare? How do you think about that? And maybe Dave, you can chime in from the rural perspective as well. How do we avoid another divide here and a worsening of disparity?
Yeah, I mean, my suspicion, I'm not sure I have, the answers. Of course, we're all doing this, is that we we honestly have to take this to the patient. And, whether it's with devices or with tablets or in the emergency room, community health setting, home health aides, physician assistants, nurse practitioners. I definitely think that that is one of the ways that we have to do it. And sometimes when it comes to consultative, when we are consulting with a patient, we may actually have to run through what we are thinking together with them so they can see, and to be able to give them, whether it's a diagnosis or a prognosis, or to be able to help with decision making. So I think that is one of the ways that we're going to have to do it from here on.
So really another flavor of radical transparency, right? We have to use the tools, we have to make it very visible when we're using them, and we have to share, instead of saying, I think your diagnosis is X, maybe it's, well, I think it's X, the AI thinks it might be Y, my colleague thinks it might be Z, so let's figure out together, what the right next step is.
Exactly.
Dave, what about the rural disparity issue as well, and broadband access, and all the infrastructure and trappings that have to be in place for a lot of these tools to run, especially if they're not edge computed? How do we avoid the problem of no electricity in rural America again?
Yeah, I really like your term radical transparency too. And I think that the most important place for it to have that transparency is with the patient-provider relationship. We've seen time and time again, and I think in the current political landscape, we're moving towards who can you trust? At the end of the day, the patient trusts their provider. In rural America, it's even more so. These providers might be the only doctor or nurse or physician assistant living in their community that they see every morning at church. What we need to have is we need to have informed providers informing patients on these things. It also, we have to think about what our benchmarks are. That frequently we compare AI to in-person care or the standard of care. In rural America, we need to change that. So rural AI can enable physician assistants, nurse practitioners to up their game so they can be compared to a cardiologist. Because honestly, a lot of my patients, they're either going to have AI-enabled care, virtual care, or no care at all. So we need to know what our standards of care are going to be and have powered studies based upon those.
You think about, I'm going to go off script a little bit here because you raised a really interesting thought in my mind, which is all of us who are physicians, we trained in the pre-AI era. I learned how to write a crappy note, then I learned how to write a better note, then I learned how to write an attending note, then I learned how to teach an intern how to write a better note, right? I have the benefit of all of this manual or analog experience. Let's just say I trained before MRI was routinely available. So now now the gray hair is real. How do we think about, you just talked about that upskilling of, providers at all levels of the delivery system. How do we avoid this risk of cognitive atrophy that people have been talking about? I start to rely on the tool so heavily that my own skills start to diminish and I begin to follow the tool slavishly. I lose that ability to be the primary generator of the knowledge. How do we avoid that risk where the human is becoming the co-pilot to the AI, not the other way around?
Yeah, I think we have to be very, very intentional in emphasizing that AI supports, not replaces the clinician's judgment. And that is we on this call, that's the AHA, that's Dandelion, but it's also the medical schools. It's also undergraduates. It is that this is being ingrained in education. And in medicine, we have to be very intentional saying that, again, I'm going to emphasize this, it does not replace the clinician's judgment. At the end of the day, a human is going to make the call on these that's going to be aided by AI.
Elliot, let me ask you to chime in here a little bit as you think about this as an AI developer and as someone who is supporting that platform model for assessment and validation, but also presumably algorithm development. How do you think about what you can do to support developers to address this specific issue or some of the previous issues? How can the platforms also play a role in helping develop better algorithms or more robust algorithms? Or quite frankly, like what happens when Pneumonia's R Us comes to you and tries to validate their algorithm and it fails? It shows that it has real vulnerabilities in certain populations. How can this platform concept help strengthen algorithms so that they actually get better? Just, your thoughts.
No, great question. And obviously, thanks for being here today, as it were, a big day for us in terms of launching this product. This is such an interesting problem when you look at it from the outside. You have these incredible solutions that people like Ross are building and this intense desire to improve, healthcare as it goes forward using AI. And yet this lack of an ability to translate that potential into reality. And from the outside, when you look at that, it's just an intensely frustrating problem and one that we kind of set out to try and solve. And the first realization I think we had was, okay, it's actually all about the data. So we found these wonderful partners in Sanford, in Montefiore, in THR, in Sharp, and we were like, let's build very intentionally a kind of representative data set. I mean, Lee, you spoke about drug development. I mean, fine, your average cardiovascular trial is like 15,000 in phase 3, but that's the peak. Often what we do is we go through these much smaller populations, approve a drug, and then suddenly it's used on billions of people.
Yeah.
And here we are with AI, and the rules are very different already, right? Ross probably trained on a pretty large cohort, but that wasn't sufficient. And the reason is because people are expecting a level of accuracy that AI can produce that doesn't exist in a lot of other therapies. And I think that's the right thing, but if we're going to do that, then we have to build the infrastructure to facilitate that. And so that starts with the data. But for us, what's so exciting about this AHA partnership is, we're a kind of translational infrastructure platform, right? I mean, that's ultimately what we're doing, but we're not clinicians. And the point made by this panel that's so forceful and so interesting is it needs that extra element of the clinician input to be able to translate into care. And so the partnership with AHA and why I think this platform is so powerful is we're kind of facilitators. We take the data, we take the algorithms, we build the technical infrastructure, and then we facilitate the decision-making process by the scientific advisory panel and others to decide and to assess how does this algorithm function compared to standard of care, compared to no care, to Dave's point, what is the benefit societally speaking? And then I think, Lee, this is the other great thing about AI. You can really assess it. This isn't like digital health when you're like, well, I think I've dealt with your diabetic population. I've got this vertically integrated solution. I'm sure everyone's fine. And you don't really have the data to back up whether or not it was game changing. Whereas in AI, we really can use the data to understand the performance of an algorithm vis-a-vis another treatment. And so that transparency, I think, will propel us to competing on quality. And that's pretty amazing. That's the future, is if we can facilitate and take Ross's algorithm that he worked tirelessly on and compare it to your point, pneumonia's R Us or cardiac amyloidosis R Us, and say, look how much better this performs. That's better for everyone. That's better for us. It's better for the patient. That's better for innovation. And so that, I think, is the big focus. How do we get this industry competing on quality and making sure that the best solutions get to market for patients?
You raise another really interesting point, which is care happens at the intersection between the technology and the patient, and whether that technology is a drug, a device, or a piece of software. And there is so much variability in how some things are delivered. So I would say take the analogy of like drug versus device, approval and dissemination. So drugs have a really high bar for approval because in part, once they're approved, if it's a pill, it's everywhere, right? It could be in every American's mouth tomorrow. Whereas devices have a much lower bar for approval, but they're disseminated slowly. People have to become expert. They get trained and they can only do a certain number a day. You can't suddenly do the procedure to 1 million people tomorrow. It takes a lot of time to build. But software, we're kind of regulating like a device, but it has instantaneous distribution like a drug. And in fact, it's a drug without a blister pack, right? It's everywhere. As a purchaser now, wearing my hat at Yale, when I go to buy a car, I do not have a bake-off for the best steering wheel, the best transmission, the best brake pads, the best tires. I buy a product that's all integrated, and then I can go from place to place and do the thing that the car is designed to do. It monitors itself, and it lets me know when I should anticipate problems. Right now in healthcare, I feel like I am going around and buying hundreds of point solutions and trying to integrate them into the equivalent of a healthcare car that I can use to, bring services to patients. And I think that is the market immaturity that we have right now. We don't have a middleware layer where these tools are getting assembled, orchestrated, and then delivered as platforms. If we're lucky, we get an imaging platform with echo and EKG, but not echo, EKG, and radiology, right? It's still very narrow, siloed offerings. So I love the idea of consolidation in the platform validation space, coming up with standard approaches, benchmarked testing, like we have in electronics, right? Underwriters limited kind of thing. What I think we need, where we need to get to, where groups like AHA can be so powerful, is bringing us to that space of market maturity in that middle layer, where we can start to assemble solutions. Now, you'll have big EHR players like Epic. They will certainly be trying to fill that niche, but they will not fill it perfectly. And there will be many products they offer where there's a better product from a freestanding vendor. And we're going to have this really hard time deciding what's better for my patients and my health system overall. A really good set of tools that all work together, or a really great set of tools that only work independently. Thoughts from anyone on the panel? Which future would you want to vote for?
Easily. I'm with you. It's got to be integrated. It's got to be, I want the entire catalog. I don't want one thing out of the catalog.
This gets to a little bit of this. I know we're not talking as much on generative AI, but this team of champions, team of really good point solutions, or a champion team, which is really good, and champion team wins in the research and in what we know about basketball and life. So I'm also with you on that.
Yeah,
Ross, as a developer of a product, right? I'm gonna guess you might be a little further on the other side.
No, I'm completely there with you. I think that is the way this plays out. I think it's really important to consider. You can have the best AI tool in the world that beats every benchmark going, but if they negatively disrupt the workflow, clinicians won't adopt it. And I think you have to combine the quality of your AI tool with the ability to implement it seamlessly in the workflow.
It's really funny. I think there are, I think many people have gone through the transition I have. As a stroke neurologist and a clinician in a big health system, I railed against Epic and pointed out all the ways in which its tools were deficient compared to my best of breed thing that I wanted. Now that I own the Epic implementation for my health system, suddenly it feels very different. Now I'm being attacked by all those people like me who have the product that they want that is just the right tool for their job, but it's not sustainable. It's not scalable. I can't maintain it. I can't maintain one FTE for every tool so that every tool has someone who can manage it. I think we have a scaling problem. And there's no lack of innovation in health systems, big or small, rural or academic. There's innovation everywhere. What there is not a lot of is scalable innovation that becomes then workflow. and no one thinks about it as innovation anymore. No one thinks about an MRI as innovation anymore. I can tell you, in like 1997, it was innovation, and the question was adoption. Awesome. Well, this is such a wonderful conversation. Let me just hit each of you with a 30-second answer. What's your one either call to action for people listening to this, or to yourself, a year from now, or to the CFO at your health system who's going to be the one who's going to decide whether you get A or B? Like, what is that? If you get that chance for the microphone for 30 seconds, what do you want that person, that leader to know or think about? Dave?
Yeah, I think whether it is, if you're trying to implement AI software or if you're a vendor trying to get into space, learn from my mistakes. It is make sure the people that understand the patients best, which are physicians and care teams, are leading the conversation. They should be the ones that are setting the guardrails, defining what success looks like, because ultimately AI's impact will be measured by how well it earns the trust of both providers and patients. Involve the people that are making the decisions from day one.
Sneha?
I think if you want to understand the true impact of an AI tool, you have to think beyond the AI tool itself. It can be the best AI tool and perform so well on benchmarks, but unless you understand how it's going to get implemented in your system, what capacity constraints you currently have or can plan to try to alleviate, unless you're thinking about financial implications, ethical implications, you will not realize the full potential of AI.
I was at a gathering that JAMA hosted, an AI summit, and one of the speakers said something I just thought was so great. If you can't solve the problem without technology, you probably can't solve it with technology. And I just kind of love that concept framing. It's not true always, but it kind of makes me, that was reminiscent to me of your comment. Like, you got to understand this all the way through, or you're not going to get the value that you were hoping for. Cyril?
I think we still have to keep the patient in mind. We have to focus on the patient and how this is really going to help the patient. I think sometimes we forget that what we're trying to do here is really to bridge the gap between the haves and the have-nots, between those who are getting the care and those who are not. And we really should be able to harness technology to get to that goal. And that is one way that we have to talk to those in charge of the healthcare systems.
Yeah, I think sometimes we run the risk of, for lack of a more refined way of saying this, aggregating the data from our patients, de-identifying it, monetizing it, and then leveraging it to improve the efficiency of our healthcare delivery. All of which would be fine if we then took the fruits of that to address those gaps, to bridge those disparities in healthcare. But yeah, I think patient front and center. It's why if we're not in this business for that reason, we probably shouldn't be in this business. So thank you for reinforcing that, Cyril. Ross?
Yeah, I would say my kind of summarizing statement is, FDA validation is great and it's necessary, but it's not sufficient. I would say an AI model's real test begins after deployment. If we want AI to reach every hospital, not just academic centers, you need a framework that combines validation, real-world monitoring, seamless workflow integration. And I think the AHA is sort of uniquely positioned to help, provide some of that framework.
And Elliot?
I mean, from my perspective, you look at this two-sided marketplace and you think, okay, it will require both sides to move. I mean, no AI developer wants to get their algorithm validated. I mean, Ross knows that. But the reality is that if you understand that by doing so, you help create, to your point, Lee, that kind of mechanism and workflow that helps facilitate scale, I think that's one of the key things to kind of get used to how do we grow this market in that sense. And then from the hospital side, I'd really talk about from Cyril's perspective of there are a handful of systems that are really very forward thinking in terms of where they are. Yourself, Lee, and Sneha work at two of them, but there are so many other health systems that really would benefit greatly from being involved. Come forward. like try this capability, see if we can start to pioneer some of these things. We'll certainly be trying it with Dave at Sanford and other places. And how can we start to give the market examples of bridging that digital divide? Because you only need a couple. And then people start to feel a lot better about it. And you know, people find solutions when they realize the value of what that solution could be. If you don't know what the value of the solution is, you're unlikely to put in the work to make it happen. And so, you know, let's start that process and get that proof of concept off the ground.
So I'm going to just share this anecdote I heard earlier in the week that has that just really touched me, and I thought I just want to share it, and I feel like it gets back a little bit to what Cyril was saying. So Margaret Mead is a very famous anthropologist, and she was asked, the story goes, she was asked by one of her students, what was the first sign of civilization in the you know, historical record? And rather than mentioning, you know, clay pot or the fish hook or some other tool, she said it was the healed femur. And she said, because in the wild, if you break your leg, you die. You can't hunt, you can't protect yourself from predators, you don't survive. But a healed femur means that someone stayed behind to help you, to feed you, to carry you from place to place until you healed. And that the first sign of civilization is not invention, it's compassion. And I sort of kind of feel like, why are we inventing all this stuff? We should be inventing it because we want to care for the poor, care for the sick, heal the injured. Really, you know, that's why we're in this profession. And so AI should always be in the service of delivering the care that we know needs to be given and that we struggle to deliver, not to, you know, focus on curing the one incurable disease for which the treatment is, you know, $8 million a patient, and not just to make our, you know, bottom lines more favorable, but it's really to bridge the gaps that we already recognize exist. Well, let me take the opportunity now to kind of turn the question back to John and Jen from AHA and give you the, you know, closing few minutes to talk a little bit about, you know, reflect on what you've heard today and also talk about what are your hopes for what AHA can do in this space.
Go ahead, Jen.
Thanks, Lee. I think just bringing all of the stakeholders together, I think, is one of the most important things that AHA does. We are a convener and a catalyst. And I think that's shown in the roundtable today from everybody we brought together. And we do great research. We're an organization that's focused on science and research, and that's our mission. And that's what we're out to do here, is find those best algorithms, test them rigorously on behalf of patients, which is something you always say, Lee, and I think that's absolutely right. John?
Well, I want to first thank the panel for an extraordinary hour of just, you know, thoughts on this leading edge, you know, opportunity for us to make an impact. The American Heart Association's mission is about providing health and hope to everyone, everywhere. And I think that's why we're entering the space. We believe there are emerging and increasing gaps in access. And that's something that, as a patient advocacy organization, we have to invest in solving for. So we're launching that effort today in a formal way. We've been at it for a couple of years, but I think this is a very significant opportunity for us to improve the implementation of these new technologies. Thank you.
Well, thank you for that, John. I'll ask our producer if we could put up that those last two slides that show folks, first of all, that if you want to ask questions, pop them in the chat now in the Q&A panel. They will be collected at the upcoming webinar. They will be answered as well as posted with some FAQs to the channel that AHA is going to be setting up. And if we go to the next slide, just a reminder, if you want to learn more or you know, even participate in this AHA AI Assessment Lab, you can email Kate. The registration to that, I think, is going to be emailed to anyone who registered for this, and there'll be more interesting content there and some case studies, really, you know, chewing into this material at, you know, much deeper level. Let me just end by thanking my co-panelists. What a great conversation, really interesting perspectives, all different angles on this same really important and thorny problem. And I hope that we'll get to continue this conversation in the future. Thanks to everyone. Have a wonderful day.
Thank you.